Myopia is no longer a refractive error. It is the fastest growing eye health challenge of our time. While we have long recognized diabetic retinopathy clinics and glaucoma services as essential components of eye care delivery, same level of systematic focus on myopia is still emerging. This IC aims to fill this gap. Myself is Dr. Anila Josh from Srinetra Eye Care. I'm a pediatric ophthalmologist there. My topic is myopia mission is changing its trajectory and why every ophthalmic practice needs myopia clinic. Everyone is saying that myopia is going to be a pandemic, and we will realize the real impact of this saying only when we compare this with the prevalence of diabetes. You can see that 50% of the world's population is going to be affected by myopia by 2050. Myopia already affects, this is a graph showing the comparison of global prevalence of myopia versus diabetes. And myopia already affects more people than diabetes, as global prevalence of diabetes is about 540 million adults and global myopia prevalence is about 2.6 billion people. And by 2050, myopia may affect 5 millions of people. That is, half of the humanity will be affected by 2050. And the speed of increase is far greater than that of diabetes. While diabetes has strong awareness for blindness, myopia does not, despite similar or even higher risk volumes. This is a graph showing distribution of people having myopia across age groups in 2000 and 2050. More children with low vision today means more adults with disability tomorrow. Myopia has impact on both individuals and society. The social effects being educational challenges it provides, psychological impact. Myopia also contributes to greater psychological stress and anxiety in adolescents compared to those without vision defects. And there is limited participation in sports, especially those requiring clear distant vision. And it also impacts the productivity. And also there is social isolation and stigma associated with it. The economic impacts including the productivity impact, because people having vision problems can affect work productivity, especially in jobs that require prolonged use of screens or detailed visual tasks. Uncorrected vision issues or simply having an incorrect prescription may lead to errors and decreased work efficiency. And projecting this onto a wider scale, a recent study showed Southeast Asia had the greatest potential decrease in global economic productivity due to visual impairment resulting from untreated myopia, and the cost of that burden far exceeds the cost of myopia correction. And also, there is increased demand for vision correction products. And also, axial myopia has its own complications like cataract, glaucoma, retinal tears and detachment, macular scar, posterior staphyloma, CNVM, etc. Myopia management is the myopia management is more about treating myopia than correcting myopia. We all know that. So here comes the importance of myopia clinic, which provides customized care like diabetic clinics. Myopia clinic provides early detection, behavioral and lifestyle interventions, parent and patient education, structured monitoring, and evidence-based treatment. So the prevention is mainly by increasing the awareness, providing risk factor modification, and encouraging the outdoor play. Outdoor play should be between dawn and dusk, and it should be at least more than 2 hours. And it is found that the time spent outdoors causes less myopic refraction regardless of the activity performed, even if it is reading or sports. So it reduces the risk of onset of myopia by 50%. So preventing the onset is by identifying a pre-myopic child, that is by identifying childs with low hyperopia, with family history, less outdoor time, increased near work, and kids with binocular vision disorders like accommodative lag and high AC by A ratio. And early detection. When is the best time to start myopia management? It is at the time of onset. Why? Because in axial myopia, there is no safe level of myopia. Every diopter matters because axial length elongation has its own complications. This is the percentage of patients with high myopia in adulthood. So it is found that we can see that the risk of developing high myopia is greater than 50% for those with myopia onset at 7 or 8 years of age. And please consider the fact that we are now seeing myopia onset at the age of 3 or 4 years. So myopia management has changed its trajectory. In the earlier days, it was only giving spectacles. And now it has changed to prescribing defocus lenses, pharmacological management, and contact lenses. We all know the factors contributing to myopia. So I'm skipping that. And we all know about the factors contributing to myopia progression also. So the myopia progression has changed from simple cycloplegic refraction alone to optical to peripheral refraction, measuring axial length, AL by CR ratio, choroidal thickness, and optical biometers are available, which measure all these parameters like axial length, corneal thickness, AL upon CR ratio, spherical equivalent, etc. And also predicting softwares like BHVA and LVPA myopia calculator is available, which help in knowing if this patient will progress or not, and which will provide a graphical map of progression. So the evolution of myopia management has came a long way from prescribing normal glasses to helping in providing environmental and lifestyle modifications. Initially, we have tried bifocals and progressive glasses, but now we have evolved. Major jump in management came with the introduction of the concept of peripheral defocus. So the myopia control now includes low-dose atropine, peripheral defocus spectacle lenses, peripheral defocus contact lenses, and orthokeratology. Also, red light therapy and contrast lenses have also gained importance. In all our enthusiasm to treat myopia, we should also keep in mind that pseudomyopes also do exist, and anxiety and stress being the common causes of pseudomyopes. A myopia clinic enhances clinical outcome by providing standardized protocols, evidence-based treatment. We can measure objective tools like axial length, corneal topo, AL upon CR ratio, etc. It provides consistent review schedules and better documentation of progress. And we have the ability to measure treatment effectiveness also. Coming to the future of myopia clinics, a lot of researches are going on this field, and myopia clinics are going to change a lot. AI-driven risk screening tools and automated alerts for fast progressors are going to come up, and a lot of biomarkers are going to be discovered, like tear film inflammatory markers and choroidal thickness nowadays. Axial length and peripheral refraction school screening will become the norm, and smart lenses that adjust peripheral defocus dynamically is going to come up, and atropine microdose dispensers, smart delivery systems, or sustained release implants like we do in retina will come up, and overnight lenses requiring fewer hours for ortho-K is going to come up, and smartphone tracking apps will be there for home monitoring. And also genetic risk profiling calculators, prenatal testing, and embryo treatment is going to come up. So AI plus personalized care is going to be the future standard of myopia management. Thank you.